right. Welcome, everybody. I am super excited to be with you all today, and thank you for joining. This is an amazing month of Heart Month, and I have the most incredible guest with me today. I'm going to read out her bio so you have a really good sense of who we have with us today. This is Dr. Erin Moran, and she's very diverse. That's what I love about this girl. She's a passionate advocate for women's heart health. She's the Associate Vice President for Go Red for Women. But what you must know about her for tonight, talking about heart health and menopause, is she's also an expert in human sexuality. She holds a PhD in human sexuality, master's in counseling, and a Bachelor of Science in human development. This woman I've known for quite some time. We become fast and famous friends together. Love it. But I really want you to know Erin comes to us tonight, not just about heart health, not just about sexual health or menopause. She comes with a really deep why. And we all know that your why, if your why is really deep, your purpose is very, very intentional. So I will let Erin share her story. I can't do it. She knows every time we talk about it, I have a little tear. So I'm gets me going every time. But you guys, this is a lady who's extremely influential in the city of Phoenix. She's doing a lot of incredible work, and we're going to have a really robust conversation today. So, Erin, I want to start out first, welcome you with all of us today, Dr. Moran, and I want you to tell everybody, why are you here? What's your why? Share it with them.
Well, first of all, Dr. Chorney, could that have been a more incredible intro? I mean, wow, maybe I've lost the case of the Mondays today after hearing that. Thank you so much. And you know that I love working alongside you, and the passion you have for helping women in so many different ways is inspiring to me truly every day. Um, but yes, as Dr. Chorney shared, my why is exceptionally personal and something that I have really looking over me every single day. In March of 2020, my younger sister, we're 2 years and 1 day apart, started feeling unwell. She was having a rapid heart rate. She had palpitations, but the most pressing feeling she had was general unwellness. She was a mother of two. She had a 3.5-year-old at the time and a 17-year-old. And she did what she was supposed to do. She went to urgent care. Urgent care told her, really don't see anything wrong, but of course, if it gets worse, please follow up with your emergency room. She did that 2 days later. In the emergency room, they did the most minimal diagnostic. She was in and out in 4 hours. And if you know about the ER, that's a pretty quick turnaround, meaning they likely didn't do too many tests. They told her she was young, she was healthy, and she was likely having an anxiety attack. If it got worse, she should follow up with her cardiologist. Well, she did that too because she knew something was not right. When she went to the cardiologist, who was a male cardiologist, he told her she was young, she was healthy, and that she was likely having a panic attack, and she should verbatim go home and take a nice bath. And 2 days after seeing that cardiologist, she would suffer a massive, debilitating stroke. The stroke would take out her entire left side and it would send her into advanced heart failure. So, if you know about how your heart beats and ejection fractions and thinking about the squeeze and pump of your heart, hers was only 10%, which means it was barely functioning at that point. So she would fight the hardest fight and hardest battle for the next 3 months. And unfortunately, she lost that battle, leaving her babies behind. And so I met with a reckoning of what now? How can this be the story? How can this have happened? She did everything she could do. She asked for help, over and over and over again. And unfortunately, she was dismissed, like so many women are. And so I started volunteering with the Heart Association just to tell the story like I am today, hoping that one person would hear it, the right person would hear it, and they would make a decision to keep pushing past us being told that it's just in our head. And eventually I took this role at the Heart Association because I realized this would be my passion and my purpose. And if I could give one little girl just a little more time with her mother, then that is what I would do. And so I've now been here coming up on 4 years, listening to these stories every single day. I tell my sister's story no less than 15 times a week. And it has saved lives. And I've people come up to me and say, hey, I heard it and I made a different decision and I'm alive today because of that. And that is the power of storytelling and sharing something that's that impactful. But just like Dr. Chorney, I sit across from women that tell me these stories that they were not heard, that they were not listened to, that they, were offered Ativan when they went to the emergency room, which is a sedative, instead of actually getting pain medication or being treated properly. And so I teach women how to advocate for themselves. I try to give them the language to do that and also the signs and symptoms to look out for because ours are different. We're not small men. So, we actually have to be researched and have to understand our bodies function differently, which is what I think Dr. Chorney and I want to talk to you guys about today.
Yeah. Thank you, Erin, for sharing your story. Every time it's like, I don't know how many times I've heard it. Every time it literally breaks my heart, right? It shouldn't happen. We know, my story. I'm a heart patient. I've been dismissed twice very seriously. So let's start there. Let's start with what are the facts? What is the rate of heart disease? We know that it's rampant, but we really need these women on the call today to understand what are the statistics and what's going on right now. And these women are from North America, Canada, and the US. What is the current statistic that we can shock them with today so we really get them to understand where heart disease is?
There's so many statistics, right, that are shocking. But the most pressing is that 1 in 3 women will lose their lives to heart disease. So if you're looking at the folks on this room right now, 1 in 3 will lose their lives to heart disease. And the part of it that is just infuriating is that 80% of those outcomes we see were preventable. 80%. I mean, that means this just shouldn't be happening. That's with education. That's a portion of it, right? What we eat, what we take in, and those are going to be the things that we want to leave you with when you think about things that you can do to prevent those outcomes. Another really shocking statistic is 45% of women over 20 years old already have some form of heart disease, right? So it means most of us do have some kind of heart disease, whether that's hypertension, high cholesterol, several forms of vascular diseases that folks might have. Most of us probably have something going on, and we don't even know how to recognize our own symptoms because there is a little to no awareness around how women experience heart disease versus men.
And that's a great point. Our symptoms, they'll say, are atypical, but they're not atypical. They're typical. They're typical for women, as simple as shortness of breath, fatigue. I just feel like I got old this month, right? I just don't have the stamina I typically have. And I really want to take us back, Erin, Dr. Moran, to, knowing that one woman dies every 80 seconds across our continent, and that all cancers combined don't equal the death rate of heart disease in women. Not that cancer is not important or any other health condition, but we really need this group to leave knowing this is important. You need to know the facts, and we need to be changing those statistics. So these women we got on here tonight, these are perimenopausal and menopausal women. So let's talk about that when we're looking at heart disease, Dr. Moran, in this population and what's going on. One of the things I really wanted to talk about is, what can this population do, number one, when we're focusing on to ensure that they're not dismissed, those signs and symptoms. We need to make sure that women are seeking care. Do you have any feedback, advice? You've heard 100 stories. What would you say to this population we have with us tonight?
Well, I think one of the most important things that we share is that our risk of heart disease greatly increases as we move through perimenopause and ultimately menopause. And so we start feeling all of these different things with our bodies. We're trying to recognize what the heck is going on. I'm right here in that as well at this moment where I'm just like, all the time, I don't understand. right? Like, everyone in my office is like, hey, calm down, or let's put the fan right next to you. You're freezing us out. But hey, you got to do what you're going to do. And one of those symptoms right there, having hot flashes 6 times or more per week, means that you are at a much higher risk of heart disease. That's a specific symptom that lets you know that you need to be watching out for other things that start to happen with your body. We should naturally be taking our blood pressure on a regular basis. I'm a daily person, but right, Dr. Chorney, we should be at least once a week that we're trying to watch what's happening, but also establish a baseline to recognize when you start to have these changes. When we think about advocating for yourself, the words we use are important, right? I had a friend just last week. She's also menopausal. She's a friend of a friend. So she's actually not my direct friend, but she's heard me give this speech 1,000 times, or even in social settings. I'm always trying to educate girl groups about what you need to be watching for. And she called me and she said, hey, I feel like I'm having these palpitations. I'm sorry I'm calling you right now, but I don't feel right. I'm starting to feel nauseous. I'm starting to feel like, but listen, I have anxiety. I've always had anxiety. It's probably just that. And I said, when you go, first of all, you're going to the emergency room. Every symptom, the jaw pain, the back pain, everything that you're telling me, these are typical symptoms for women when they're having heart attacks. So I need you to go to the emergency room. You're going. But one, do not walk into that emergency room and say, hey, I think I might be having anxiety, but it could be a heart attack. Do not go say that. You walk into that emergency room and say, I think I'm having a heart attack, period. End of story. Because you want them to move on that track that says they're going to do everything that they need to do to rule that out being the number one cause. And so we don't want to plant the seed of doubt. They're already thinking women are just anxious. You know, if you look at the root and the history of medicine, hysteria, if you know about that, when we're hysterical, it really meant in medicine, something was wrong because your uterus had floated out of its spot and it was somewhere floating around your body. So you're hysterical. And the only way to fix that would be to have a baby, and then it would go right back down to where it's supposed to. So pain in your stomach, that's not really pain. You're just hysterical. Let's not plant the seed. They already have that, more likely to think that that's what it is. So one, you're going to say, I think I'm having a heart attack. And we also have to talk about stroke in this same time frame because these are very closely related. So symptoms of stroke, fast is what you need to remember. Facial drooping, arm numbness or weakness, slurred speech, time to call 911. That is what you need to be. If you remember anything from this, please remember that when you walk away, because time is tissue. And that's what they say. The more time you passes, the more brain tissue you lose, the less likely we will see a good outcome, right? The other thing that for me has been game changing, and every family member and other person, patient that I teach this to, is the words differential diagnosis. And so when you are in a hospital setting specifically, and you go there and you have been checked in and they say, hey, I think it's just anxiety. I think it's just this. We're going to let you go because we're not going to run any further diagnosis. What you're going to say is, okay, you think this is anxiety. What is your differential diagnosis? And what's that says is, sure, this could be anxiety, but what are all the other possible things that this could be? Once they start listing out a few of those things, you then ask them, what have you done to rule those out? Now you are putting some direct liability back on them and says, let's get to it. Let's do this test, the scans, whatever you got to do to make sure it's not that, because you're not sending me home if it could still be all these things and we've done nothing to rule them out. So those are some of the most powerful things. The last would be, and I think Dr. Chorney and I have both had this experience, get a second, a third, a fourth opinion if you have to. Make sure that the doctor that you're engaging with, even if it's in just a clinical setting, you feel heard. You have to feel heard. If you're feeling like you're being dismissed, you're probably being dismissed. You know, we don't know what a doctor has gone through in that day. Maybe you're the last patient you've seen out of 50 and they're just exhausted. You know, there's so many things. Doctors are human. And I know from myself, even from a young age, I was taught, you know, we put them on this pedestal that they're all knowing, but their training, their bias, Everything could be different or just their day. And your life is in your hands. So if you feel like you're being dismissed, you need to be able to, okay, I hear you. This is not a good fit. I'm going to go get another opinion and go seek another opinion. For me, I got myocarditis through COVID in the very beginning in March of 2020. And I felt like I was having a heart attack for literally 6 months. 3 male cardiologists told me, "Oh, you're probably just anxious because of what happened with your sister." And no, it's fine. We don't need to do anything. The fourth female cardiologist that I finally went to did the right test and said, "Oh, your entire heart's inflamed on that side. Wow, they didn't do a test for that?" Finally gave me the medication, and it was feeling better within literally 1 week from that. But I went 7 months thinking that this is just how I was going to have to live. So, I'm curious from your side, Dr. Chorney. I mean, you see patients regularly, right? And so what do you tell them to do and really kind of, help them push through the systems that you navigate through on a daily basis?
No, super good point. I'm probably one of those rare people who actually listens,
Yeah.
right? Because we're such good advocates. And so I do have a little bit longer appointments, and I really want my patients to feel, that they're really being listened to, that I'm kind of rolling over those stones and I'm taking that time. And you're right, I do get a lot of patients who have been previously dismissed, and then they hear about me, they come to me, and it's like a breath of fresh air to say, wow, you really took that time. And to do the workup, like, Dr. Moran, that's a really important point. They still deserve that workup, and those differential diagnoses have to be looked at. Yeah, maybe it's anxiety, but maybe it's not, right? And of course you're going to be anxious if you're worrying about it, so it's a double-edged sword, so it can't be dismissed. I want to take us on to the journey of, so we talked about vasomotor symptoms. You mentioned that. We know that increased vasomotor symptoms, night sweats, increases the risk of cardiovascular disease, women on this call. You need to know that. If, according to the American Heart Association, they do have a published ACC, which is the American Cardiologists College of Cardiology, hot flashes and night sweats. And that means you're really having a lot of those. Typical woman has them for 7 to 10 years, tends to be higher in Black women and longer in Black women. Really important to recognize that. But we know that decreased estrogen is cardioprotective, but as it decreases, it's affecting your endothelial dysfunction. Then you're not sleeping, then your cortisol levels are going up. Then all of a sudden, we're not eating properly and we're gaining weight. But we do know it causes effects of pushing our blood pressure up, all of those sort of things, increasing the risk of plaque burden in our coronary arteries. So, Dr. Rand, we know this group has to understand, number one, what are the most, we know about the life essential aids, but when we dig deeper for just it being in menopause and those sort of things, I love your words of wisdom about things like looking at, sleep and, all those amazing parts that we know are so essential. So if you could give them a little bit of a preview, it's called the Life's Essential Aids.
Yes. So life's essential eight is essentially four inherent risk factors that we have. So blood pressure, cholesterol, blood sugar, and of course one's going to escape me because it would at this moment. You might know it, dive it in. And then four behavioral attributes that we can control. All of these things we can know our inherent risk, inclusive of your familial risk. And that's something that's super, super important that I think sometimes we skip over because we don't correlate or think about, you know what? My grandfather had a stroke. My mom's dad had a stroke. My mom has heart failure. My mom's sister has heart failure. And you're not even thinking about it because you might think about different causes, right? So really knowing that and communicating that. That's one thing I just wanted to bullet because we're going to talk about that when you think about advocating for yourself and how you can. When you share that with the doctor, when you're going into these appointments, they're going to automatically start going down that path because we know that you could have a hereditary risk factor. But also when we think about lifestyle, what are we eating, right? They say the Mediterranean diet, along with lean meats, fish, coloring your plate, fruits, vegetables, is exceptionally important for us. It is. And I know I'm guilty. I just today was like, I don't need to eat another French fry because it's like my go-to after the Super Bowl. Let me feel better. But it's so, so important. We are what we eat. There is no getting around that. And one thing Eastern medicine does much better is look at that holistic view of a human rather than trying to put us in silos, understanding that our body is everything is connected, and our gut health, and you've heard about that more, controls so much of our body. So paying attention to what we eat, I know you hear it, but it is imperative. Moving is so important. So the American Heart Association recommends 150 minutes of exercise per week, and that's moderate to high. So, I mean, walking is excellent, right? We all want to walk, but I don't want you walking like you're moseying through the grocery store. That's not helpful, right? That yes, moving, all movement's good, but you need to be starting to get your heart rate up, and you should feel your heart rate pumping a bit. And I'm not saying go sprinting, but a brisk walk will get it done. And that also has so many other health effects when you think about preventing dementia and Alzheimer's. They say it's one of the leading ways to prevent that is that exercise. Again, not smoking cigarettes. Tobacco is the leading preventable cause of heart disease and stroke. And that we know we had made huge strides when we took cigarettes. We really started campaigning and marketing against these things and understanding the health risks. In so many other countries, you go and you see like that danger sign. I don't know if you've traveled to Europe or Mexico, they literally have it plastered on it that these are as dangerous as you can get. And they are. Unfortunately, here comes vaping and e-cigarettes, and people think, oh, well, it doesn't smell, so it's not affecting me in the same way. And they really kind of marketed it as this great way to get off of cigarettes. Most people do not realize that the e-cigarette contains the same amount of tobacco as the entire pack of cigarettes in one pod. So not a great way for us to transition off of cigarettes.
Can you say that again for everybody? I really want them to hear that. I
Yeah,
see Becky
it's
putting her
true.
thumbs up. Erin, say it again. How much is in one
Yeah.
vape?
Becky seemed like she already knew that. Yeah. One entire pack of cigarettes worth in one e-cigarette. So it is absolutely horrible for you. It is. And it is not a way for you to end smoking actual cigarettes. It is just a way to keep you hooked. And that's their clever marketing that they've done to get people now, one in two teens currently vapes. So if you're not checking your kids for that, if you have kiddos on this, it's a good chance that they've been exposed or at least tried it. And we know 95% of habit is formed for people trying cigarettes prior to 21. So big important thing to refrain from that. Me, I'm missing a couple. Help me out. What do I got?
The last two are know your blood sugar. So you got to keep your
Yep.
blood sugar under control. Very, very important. Diabetes increases your risk of cardiovascular disease. So if you have diabetes, it's the same things Dr. Moran's talking about. You got to get moving. You got to eat healthy. Get your blood sugars under control. You want to get some weight maintenance or weight loss going on. And the other one is you need to know your blood pressure. She talked about 130 over 80 or less. I do not bargain. Close doesn't cut it. 132, 134, 136. No, it's not in control. These outcomes of women having hypertension is a lot worse than it is for men. And that was from a large sprint trial. And finally, Dr. Moran talked about it. You need to know your cholesterol. You need to be getting your cholesterol taken on a regular basis. And again, you want that under control. When you're in menopause, what's going to happen is your LDL, which is the causal factor of cardiovascular disease, stroke, it's the bad one that lays the plaque, it goes up in menopause. Your total cholesterol will go up and your HDL will go down, and that's the cardioprotective one. So you need to be aware, you need to be on top of that. And I get so many women, Dr. Moran, who say, I don't want to take statins or I don't want to take Zetia or any of those medications. I really, really want to implore you to you need to get your LDL down. One of the things that's really important is I get women who coming in, Dr. Moran, with high HDLs, and their LDL is also high, and they're getting told not to worry about having having a high cholesterol. And that's where I love that coronary artery calcium score. Go get that done. Yes, I see Erin giving the thumbs up. Low dose radiation. Radiation's equivalent to a mammogram, so very low. Go get that done. It's usually cash pay everywhere we go, about $150, but it will help risk stratify you. Do you have plaque in your coronary arteries? The score should be 0. And if
Yeah.
you do, then we really need to look at that, and look at what are the avenues that we're going to get that down, plus harden that plaque so it doesn't lift up and go away. So, really important aspects when we're looking at menopause and how our cholesterol goes up, we'll see a shift in blood pressure, our endothelial dysfunction is getting worse, our risk factors go up. And so we really, really want to do all those things Dr. Moran said on the life's essential 8s.
And
Then
I
you
just gonna
pipe in,
repeat,
girl. Absolutely.
someone in the chat there asked, so the calcium score is what she just said. It's a test that you need to have done. And on that vein, I would love if you talked a little bit about the difference, even about how women build plaque, where maybe it's not so much in your main arteries in your heart, but more in your small arteries,
Yes.
your microvasculature.
I just gave a big talk on that today, actually. So there's 2 kinds of blood vessels on your heart. One is called epicardial, and those are those big ones on the outside that we typically hear someone had a bypass. And so there's the left main, then the left circ and LED, and the right coronary artery. Then amongst all that is called the microvascular circulation that Dr. Moran's talking about. And it is thousands of blood vessels that are all through the muscle. They don't show up on angiogram or any kind of easy imaging. It takes things like MRIs and those sort of things. But women have more microvascular disease than macrovascular disease. And so that's really important for you. We are called very dominant for that aspect. And so women can have an increased risk of vasospasm, they call it atypical angina, and again, we're not atypical. We really dislike that word. But you need to understand it's not just about those big vessels, it's all those little ones that can have effects from, plaquing, vasospasm changes. And there's work that can be done on there. We'll give someone some amlodipine to decrease the vasospasm, and they feel amazing when they get on that. So great. Thank you for having me, highlight that to them.
Well, the reason I wanted you to share that is because so often, the angiogram is not necessarily going to detect these
Yep.
things. It could totally miss it altogether. You could go get this test, and then they're like, nope, you're good, but you're
Yep.
not good because you're still having these symptoms. And then they're trying to think, why is that? Well, hey, if you guys have this information, you can help guide them and point them. Well, maybe we need to push a little further, but that's what is helpful about this calcium score. Because even if they're not seeing it where they think they should be looking, well, if your calcium score comes back and it has these numbers, which tells us it's high, there is plaque there, then hey, maybe we need to do a little more digging. We need to find where it is if it's not just jumping out to them on the kind of standard test that they would do that is most effective for the way men experience heart disease. So that's why I had to double click on that there. So when we think about, again, for women, what you guys can do right now, we missed one, so I just have to say it again, sleep. We've kind of glazed over that, but that is so, so important. And I know it's hard for a lot of us, but there are things that can help. We need to be getting 7 to 9 hours of sleep per night, especially at this point in time. Our body truly does so much cell turnover. It does magic in those hours, and we have to have it. So if you're noticing with these changes in your body that sleep is not happening, then you need to go see a specialist because they can help you with sleep hygiene. There are medications, there are other types of ways that you can start building into better sleep habits, because that is so, 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 so important. It's one thing that I've always struggled with and have to really be intentional about getting as well.
Yeah, super important. I see a question on the side, and I'm going to take this question and then get us to wrap up. So someone said if you have family hereditary elevated cholesterol or an LPA, this is a much higher risk. So they're two different things, actually. So familial hyperlipidemia, which means a genetic link, is about 1 in every 250 people. And that typically is an LDL greater than 190. So it's a very high LDL. We're shooting for LDLs less than 100 for people without cardiovascular disease. And you all know that I specialize in cardiovascular genetic testing. So that doesn't mean that you don't have family polygenetic risk of other things going on, that your family has an increased risk of heart disease or those sort of things, but they're very distinct. The LDL is quite high. On the other side is the lipoprotein A, which is called the LP little a. That is not genetic testing. It is a marker, and I do recommend you all have that. We test you at least once in your life, and it is a marker of risk within your cholesterol panel. So how I explain that, it is not genetics because it's not DNA, but it's a marker looking to see, I explain it sort of like, do you have increased risk or inflammation within your cholesterol panel? And that LP little a will increase again during menopause. So it will uptick again. It will stay relatively the same throughout your entire life. But if your LP little a is high, and you're again one of those women who's like, my LDL's high, but I really don't want to take anything. You really need to be thoughtful about that because it is telling you you have elevated risk. And then we have polygenetics. So coronary artery disease, so plaquing in our coronary arteries, does not have a genetic test. It is, as Dr. Moran and I are talking, linked to many things within our lifestyle, perhaps our family history, all those sort of things. And so we're now seeing that there's the ability to do polygenetic risk scores, and we see there's little pieces all over that are contributing to what's going on. And the biggest thing that we really, Dr. Moran was saying, is it's preventable. 80% of heart disease and stroke is preventable. We just need to be making the lifestyle adjustments. We need to move our body, sleep, get our blood pressure under control, cholesterol, watch those processed foods, all those things we're talking about that promote amazing heart health. And I know I talked a long time. Erin, I really want to let you say the closing remarks. I really want to thank you for being with everyone, with all of us tonight. You are an expert in this field. And, what if you had a message to leave all these women? This is Heart Month, and you and I are out there advocating like crazy. What do you want them to know in closing?
Well, again, thank you so much for having me. I really hope, and I see people writing notes, and I love that. Like, it gives me so much joy just to think that we can give some takeaways. But the number one thing is that this time on this, in this lifetime, it is yours to determine. There are some things that are out of our control, but there's a lot that is inside of our control. So though it may seem like a burden to get up and do that exercise, and you're like, hey, I'd rather just take this medication, understand that all medications also have other effects to your body. So yes, while it might solve one problem, now you might have 5 more. But if you did the exercise and ate a bit better, then you might be able to bring your cholesterol down on its own. You might be able to get your blood pressure in control on your own. Now, that's not 100%. It's certainly not. That's why there are medications and things like this. But should be a first line of action. And if you just make the time, self-care is not selfish, right? To carve it out. I know for people that are still working, putting a little block on your calendar. If you're not, then, and you don't have a full schedule, then I don't want to hear the excuse as to why we're not doing the activity, because we can control so much of this. Again, 80% of the outcomes we see are preventable. And remember, that's time to make one more memory, to do that bucket list thing. I just jumped out of an airplane at the beginning of this year with my 77-year-old father, because it was something he always wanted to do, and I needed to stop letting fear hold me back also. And so making those memories, and this is the way that you are going to give to yourself to be able to do it. It's the gift that keeps on giving. So thank you so much again for having me today. And I hope you guys had some takeaways.
Thank you, Dr. Moran. And thank you, everybody. Have an incredible evening. Thank you for joining us.